Good evening to one and all. On behalf of Hamsa Spine and Brain Rehab and Global Rainbow Foundation Mauritius, I welcome you all for this webinar on advances in neuro rehabilitation, followed by the panel discussion on speech and language disorders in brain injury. I request our beloved speaker to start his presentation. Before that, it is my pride and privilege to introduce our respected speaker, Dr. G. Balamurali. He is a consultant spine and neurosurgeon, the head of spine surgery, Kaveri Hospitals. He is a director of International Spine Academy, iSpine. He is a managing director of Hamsa Spine and Brain Rehab, and he is the honorary adjunct professor of medical sciences, Sri Balaji Medical College and Hospital, Chennai. Dr. Balamurali is an internationally trained spine and neurosurgeon with 16 years of surgical experience from UK. Extensively trained in the niche aspects of spine surgery as a part of 3-year fellowship programs in UK, US and Switzerland. He is a senior spine and neurosurgeon in India since 2011. He has a big list of publications, textbook contributions, international and national conference presentations to his credit, which are worth appreciations. Now I invite a respected speaker, Dr. Balamurali, to deliver his speech on advances in neuro rehabilitation. Welcome, sir.
Thank you very much, Dr. Karthikeyan. I just want you to confirm if you can see my screen.
Yes, sir.
Yeah, you can see my screen, yeah?
Yes, sir.
Okay, fantastic. Hi, good evening, everybody from India and from across India as well. I believe we have some participants from Mauritius and other parts of South Africa. I welcome you all. So this is going to be the beginning of a series of lectures and talks that we are going to do in terms of neuro rehabilitation starting from today. We will come to that at the end. But first of all, I'd just like to mention a few words of thank you to the Global Rainbow Foundation, Dr. Armugam Parasuraman and Dr. Karthikeyan for having given me this opportunity to collaborate and work in these presentations. So we are going to have a combined meeting on a regular basis, and we invite all of the participants who are here today to benefit from this educational program. Now, I'd just like to mention a few things about Hamsa. So Hamsa Brain and Spine Rehab is about 1.5 years old, based in Chennai, in Tamil Nadu. And we are a 20-bedded center where we have all of the rehabilitation facilities that are required. So we have physiotherapists, occupational therapists, speech therapists, we have psychologists, we have nurses, and various other people. I welcome you all again, and let's go ahead. So the topic I'm going to discuss today is called advances in neuro rehabilitation. So the reason why I have taken this topic is you're going to be seeing a lot of advancements and advanced technology that's going to rule the way rehabilitation is given. Here by advances, I don't mean just by telemedicine or by virtual conferences and meetings and patient discussion. We're going to really see hardcore advances which are there in neuro rehabilitation worldwide. Some of this technology may be in India or may not be in India, but there are a lot of this that's coming into the third world country and developing parts of the world as well. So first of all, I'd just like to mention to you that there's always this debate which we have in our mind about whether we need to have early or late mobilization, early versus late rehabilitation. The reason I picked up this line is because the earlier you do your rehabilitation, the more advances that you are going to require in the future. So if I can say, if you look at what are the evidence about early versus late neuro rehabilitation, there's plenty of evidence that says that in an organized neuro rehabilitation multidisciplinary center, the rehabilitation benefits to the patient are much more compared to those in a smaller center, where you don't have a structured protocol-based rehabilitation. So there is plenty of evidence both in terms of stroke rehabilitation, brain rehabilitation, or whether it is spinal cord injury rehabilitation. A lot of technology and other advances that I'm going to show you today is going to be all a lot based on spinal cord injury. The reason why I've taken spinal cord injury specifically is because spinal cord injury is one of those category of patients who can benefit the best out of a structured rehabilitation program. Because if somebody is either paraplegic or quadriplegic, he can be maximized to a great level of ability from disability. Unlike a severe traumatic brain injury or a severe stroke, no matter what you do, if there is no cognition, if there is no significant improvement in their understanding, rehabilitation may not be that successful however good you are, because the brain damage is so bad that you're not able to do so much things. Whereas in spinal cord injury, you can do a significant amount of difference to the patient. Now, early versus rehabilitation, the benefits are, one is the complication rates of DVT, pulmonary embolism, pneumonia, UTI, myocardial infarction, sepsis. All these are significantly reduced because the patient comes from an acute hospital straight to a rehabilitation, and you start all your intervention programs very early. As well as from the time between the surgery and the patient being mobilized, the shorter the interval between these two is, the better is the outcome, and the complications are less. And also prolonged bed rest in a hospital is always associated with greater number of complications. So the type and timing of rehabilitation, in a spinal cord injury patient, there's been a systemic review done by the Global Spine community, and the association between the increased time from injury to rehabilitation and poor quality of life and performance of ADL. So it's a retrospective observational study, but they said there is a strong association between the time of injury and when they come to rehabilitation. So the take-home message really from this point is that your patient should come from a acute setup.
We will continue.
Straight on to this.
Anyway.
So what is early rehabilitation? How early is early? People say that the early rehabilitation can be anything from about 3 weeks to 6 weeks. So, the patient should come within that period, and once they are medically fit to a rehabilitation center. So early rehabilitation, as I said, always means advances. So what are advances? So let us talk from very basic. So we all know that skin care is so important in preventing bed sores and other bed sore management. So on a research basis, we usually have a 2-hour turning in bed. But this, with research, has been found that if you can actually do a turning of every 4 hourly rather than 2 hourly, but at the same time, you're also using a pressure distribution surface like an air bed or any special bed, then you can increase your time to 4 hours. If you don't use them, then every 2 hours you have to change the patient's position. When you're coming to respiratory complications, we all know that, air toileting and suctioning is so keen, especially patients with stroke who do not have a conscious level, patients with high spinal cord injury who do not have their respiratory muscles intact. So early tracheostomy, early weaning out of ventilator, and early suctioning has huge advantages. So this is again an advancement that sometimes when I operate a patient who's a quadriplegic and high cervical spine injury, I do a tracheostomy during my primary surgery. So I do my spine surgery at the same sitting, I put in a tracheostomy as well. Whereas previously we used to wait for 2 weeks, 3 weeks, they're on a ventilator, and sometimes they get ventilator associated pneumonia and everything. The same with stroke. When I do a traumatic brain injury, as soon as the traumatic brain injury surgery is over, within 2 to 3 days, we do a tracheostomy on the bedside, get them off the ventilator very quickly. So this is again a big advancement. Now, pain management has gained a lot of importance because pain is an integral part of stroke or from spinal cord injury. Pain is always a major problem. So, there are so many advances for pain management apart from medication, because sometimes medication really does not work for some of these patients. And so we do spinal cord stimulation, intrathecal spinal pumps for morphine pumps. We use electrical stimulation or deep brain structure. So you use a deep brain stimulator. So all this leads on to also for chronic pain. So the treatment may be able to provide a considerable pain relief by alternating treatment modalities such as medication, physical therapy, and then if all this fails, you also go ahead and you give some, advanced pain therapies through this. So a spinal stimulation, we have done spinal cord stimulators. It's a modern spinal cord stimulators are programmable, so you identify how you want to program, the type of leads that you want to keep. So there are, multifaceted leads, there are broad-based leads, there are single leads. On which side, if the pain in a stroke patient is only pain is unilateral, then you can have a unilateral lead. And this has, plenty of evidence that it works. Unfortunately, in India, one of these leads would cost you anything from about 5 to 6 lakhs, the lead alone. And you have to first have a trial lead followed by a permanent lead. But still, there are a subset of patients or category of patients who will require this. Then the next problem are intrathecal pumps. So previously, when they have severe pain, you have very little options of pain management. So now we have, intrathecal pumps, like morphine pump or a baclofen pump when spasticity is there. And you all know that significant spasticity can cause pain. So the worsening the spasticity, the more the pain. So we use intrathecal baclofen pumps. And this is how a pump is placed. So this is a round cylindrical structure that is placed in the patient's abdomen, and there's a catheter that goes all the way into the patient's spine, and then you are able to inject it. So this pump is filled with baclofen. In India, baclofen is allowed. In the US, morphine. In Europe, morphine can also be used. In India, at the moment, we don't suggest morphine. It's not licensed by the government. And every 1 year, 2 years, you just can fill this pump from outside. So you don't need to do any operation again. You can just use a small syringe, and there's a small area in there through which you can actually do the pump. Then you have bowel irrigation. So for bowel irrigation, you have various devices that you have, where you don't need to do anything apart from using this pristine system, where you place this in your anal orifice, and you have an irrigation system through which you can clean. So this helps you with mobility, moving around, doing your regular chores. Similarly, you have the bladder stimulators. You have bladder stimulators which control your bladder. A bladder stimulator can also be used to control your bowel, and also it can also cause sexual erection. And you can have so many other devices and advances that you have in patients with spinal cord injury for sexual activity as well. So you have this system which is called as the Brindley procedure, which combines a sacral anterior root stimulation with rhizotomy of the dorsal roots. And this is another method in which you can use. And as I said, it can also be used for sexual function as well as bowel management. Now, coming to technology, with the advances in technological devices and computers and robotics, I'm sure, like in any other field of technology, medicine has definitely advanced a lot. So I'm not going to touch upon the technological advances in diagnosis, like diagnosing a stroke. You can pick up a stroke very early nowadays with a very high resolution 3T and special sequences of MRI scan. You can do various types of stimulators where you can pick up spinal cord injury and the amount of spinal damage. And soon we'll be able to predict the spinal damage by identifying the tracks, the disconnection of tracks. So we have so many advances in imaging. But I'm not going to talk about imaging, but I'm going to directly talk about the tools that are used for therapy. So we have a huge variety of virtual reality tools for detecting hand function. It is like your Sony Xbox or your Nintendo Wii. So it's all a similar principle where through infrared it detects hand motion. So you're able to control balance, hand function, eye movements, neck movements, body movements, pressures. So various devices have been generated over a period of time. All it requires is a simple computer, a software, and a motion sensor. And with this, we are able to do a lot of new advanced technological things in terms of virtual reality. So we also have the enhancing or replacing surviving functions. So there is a network of nerve cells in the spinal cord called the central pattern generators, CPGs. These produce rhythmic walking patterns. So this has been tested in animals, and they've identified that when you are put in through a rhythmic pattern of walking, your joints get used, your muscles get used, and these networks may be able to retain after the spinal cord injury by repetitive movements that activate the muscles needed for walking and standing. So with this device, so we have these various functional electrical stimulations. So we stimulate the muscles to produce a certain function. And by producing this certain function, you're able to do this repetitively, and so the patient can slowly strengthen his muscles. So the functional electrical stimulation and the neural prosthesis system. So you combine this with some neural prosthesis, you're able to give the FES can provide the user with control of muscles to assist the function via an electrical stimulation delivered programmed pattern of small electrical impulses to nerves that activate movement. So these electrodes can be tapped to the skin, and you can program either using a computer or through the hand, and you can keep stimulating, and these impulses are carried by the nerves and the muscles work. So this is again, this technology is a little bit, outdated. And now we have, direct stimulations, which you can directly stimulate the nerve through electrodes placed inside the body or inside the skin. So the implanted, FES device, this is, intended for an restoration of hand function in a C5 and C6 level tetraplegic, where you have like a pacemaker, which is wired into the muscles, and this muscle is causing hand function, and use of fine motor functions of the hand. So there are 8 leads come from the receiver stimulator and pass under the skin to a connector side of the upper arm. They are joined with electrodes, and they're passed under the skin to the forearm and arm. So you can program it, and when you start thinking about using it, you will find that this gradually improves and gets better. Similarly, we have freehand systems. So the freehand system is similarly a power and control signal are passed through the skin to the receiver stimulator from the skin mounted coil. So these coils are placed, the implant is stimulator and the electrode is placed, and the coil is kept outside the body, so you can use it if you have a normal arm. We use this sometimes in brachial plexus injuries. So the hand opening, closing, the strength of the grip, the proportion to the distance of the object, all this can be learned. It takes time. It is not just only the technology, but it also takes a lot of time for you to go gradually and learn it and get used to it. So it's a trial that after the implant is placed, you have to have several months to years of training to get used to it, and the body has to learn it. So there are lots of FES systems for hand function. So for the leg, you can see, a patient is suspended on these belts and can do gait functioning. So there are so many devices available in the market. Yes, they are expensive, but I just really wonder and wish that we start developing these in the developed world, so they are made relatively cheap and available to a broader group of people. Then you come the robot-aided neuro rehabilitation. So this robot-aided neuro rehabilitation, a robot is, programmable. So we have robots which do multifunctional, manipulated, designed to move the materials or parts. So you have initially the older devices where you had the robot that controlled the movements. So this started as early as 1980s. So we had robots, and robots have been put into use in every manufacturing industry. They feel that in Japan there would be about 1/4 of the population in the next 20 years will be robots. So robots will be used to clean your house. Robots will be used to talk to you. Pubs and restaurants, the servers, the maids, everybody will be replaced by robots. So when we are in a technological world like this, so you can see the number of devices that have been available, where you can use so many things that robots can do. And this is an evolving area. which I'm sure some of you may know better than me as to what's available. Then you have the next thing called as the brain-machine interface. I'm not sure how many of you have seen this. So if somebody has a cervical spine injury, and especially if they are quadriplegic, they don't have any hand function. Now, how are we going to bypass the brain function through the spinal cord? So there are 6 devices in the world right now, and many of them are not only in the trial phase, but 2 patients have been implanted in the US. The US FDA has approved this. It's very expensive, but many universities have got this, and I have had the opportunity to see one of them when I was in the US. And this is an interface that bypasses the spinal cord. So directly when the patient thinks about movement, you will have movement in your fingers or hands or legs. And so then you come to the exoskeletals. So these exoskeletals are devices which has a biomechanical variance where you can move the joints, and it is operated electronically to provide a gait assistance to spinal cord injury patients. It is available in many places. In Chennai, we have a couple of manufacturers. So in Hamsa, we are going to collaborate with one of them in trying to use these exoskeletals for some of our spinal cord injured patients. I think this is a great device. I think it needs a lot of improvement from what I have seen. But if you have good improvement, then yes, this could be a simpler, a cheaper solution, because it's not that expensive like the robotic arm or the robotic leg. So these are the ones that are very expensive. It's been used by the US military for patients, for people who have been affected in the war and various other places. These are well designed, battery operated. It's almost like a robot. So a patient from a wheelchair, he can be trained to walk with wearing one of these devices. So the robot gait trainer we have actually one I've seen in Delhi in India. So there's a robot gait training system. It's called as a Locomat, and it uses the muscles active. It's an active leg exoskeletal system for the lower limbs, and this is how it functions. If you can see, so the patient uses this device. He holds on to it. He is suspended from a device above, and he is able to walk. So this gradually strengthens the muscles, and as I said, you can train the muscles to do certain functions. Then you have the power assisted propulsion for manual wheelchair. So the wheelchair can become motorized and you can control it with your joystick. This I'm sure a lot of you have seen. Recently in Chennai, IIT of Chennai designed a standing wheelchair where a patient can, from a sitting position can stand. It's been there in the market for about, nearly 5 to 10 years. But this has been recently, redesigned and made very cost effective. I believe it's one of these costs about 20 or 30,000 or maybe less. This is a standing wheelchair which is motorized. Then you have mouth controlled wheelchair for quadriplegics, and you have so many other devices. So you also have these automated stair climbers where a patient can climb up stairs. You can't lift them. See, all these things are very essential to improve your quality of life and independence. If you have somebody living in the first floor or in the second floor, and if you're stuck that you're not able to bring your wheelchair, and a lot of apartments and houses don't have a lift, then you're really into problems. So these devices are going to become more and more coming in the market. We also have these adaptive driving devices where if you have a good hand function but no leg function, so all your leg function can be controlled through the hand. So you have a hand control system. And the vehicle modification is endless. I mean, Chennai, as far as I know, has 2 companies who modify vehicles for disability. So this is very, very advanced. So this is not just for only patients with spinal cord injury. It's for patients with amputees, for upper limb or leg amputation, patients who have crush injuries. So many of these patients, they can benefit from all these advanced technological devices which can be modified and adapted into our routine vehicles. So here's another patient lift. So you can go down the stairs, the patient can sit down. There are other devices which are called as environment controlled units. So these devices again help spinal cord injured patients to control electronic items. They consist of an input device like a keyboard, joystick, switch, or voiceover that can be used to send a signal to produce a desired activity or a feedback. So this can either be used in something like a brain interface, or you can have devices which can use your wheelchair control, or you can have devices which can open your curtains, we can switch on your television, you can open your door. So many other things which you cannot do because of mobility issues, you can do. So here you can see patient can use these special devices in the car, at watching television, playing video games, um, and there are so many voice recognition systems. The one popular one is a Dragon system, which identifies various different muffled voices. Even if the patient does not have a good voice control, it can be identified. And there are so many switch adaptable devices which are available, and these all help with various pressure sensors that you have to provide a specific function. And you also have the sip and puff. So if the patient is a high quadriplegic or a brainstem kind of an injury where they can only puff or sip, so this can also be used as an control mechanism. Now coming to some of these tetraplegics who have a problem with the hand function due to either severe spasticity or neurological damage. So they need to undergo through a systematic way. So in the initial phases, you use various, calipers to try and correct them, make sure they don't develop any spasticity, they don't develop any contractures in the hand. And then step by step, you move on to using various devices. So the initial phases is splints and special devices and to protect complications. And the more advanced now is we have a plastic surgery department where we actually have started to do various devices, tendon transfer operations. So if you have a flexor component that is functional and the extensor is not functional, then you can do a transfer from the deltoid for the brachiobiceps. So you can use the extensor carpi radialis. You can use the FDPs, the wrist extension, flexion. So many other combination of things can be used. There are so many sling procedures, tendon transfer procedures, the brachioradialis to the ECRB transfer, and the flexor pollicis longus tendons. So depending on your assessment and depending on what function the patient requires, what job he does, what is the real function that you need for this patient, then you can try and do so many changes and so many modifications. Obviously, this needs a lot of expertise, and I'm sure there are very few people around in the world who do these kind of procedures. And once you do these procedures, at least the patient can use a joystick. The worst case that he does not have both hand function in a quadriplegic, he needs the minimum if he needs is to hold the joystick and he can maneuver through the movements of the elbow and the shoulder, and this can be planned. So it's a teamwork between the surgeon, between the therapist and the occupational therapist and various other things. And higher groups, more complex reconstructions can be done. And these are all the various procedures available. I don't think this would be of interest to you. The next group is we can do nerve transfer. So you can transfer a nerve alone and you can attach the nerve to the other side. For example, when you have a brachial plexus injury, so we use the nerves from the opposite side. The accessory cranial nerve is rotated and we move to the other side, from one side of the body to the other side, and use them. And you can get good elbow function. I've not seen very successful hand function coming up with brachial plexus surgery, but this is something else. And for brachial plexus at Kaveri Hospital at Chennai in Hamsa, we also do DRES lesionings. It's an operation for the pain management. So when patients have severe, pain, intractable neuropathic pain, we do procedures where we can get rid of their pain, and we have a huge success with about nearly 40-50 patients that we've operated in the last 5 years. So I'm going to now show you some pictures, and this is a person who I have met when I was in London 2 years ago. And she was an Paralympic sports person, and she was an T7, T6, T7 level paraplegic. And you would believe that, okay, a T7, T6, probably, even to get a trunk control is not going to be very easy for such patients. And this person, she was able to do various maneuvers on snowboarding. So this is the pictures that, she shared with me, and she represented Great Britain for the Paralympics, and she won the third prize. And so this is the pictures there, and an Australian, I think, won the first prize. So the reason I'm showing about Anna Turney is you can push your limits with the help of various technological advancements, and the limit, we still think about trying to make our patient stand, trying to make our patient mobilize from one room to the other, whereas the Western world, the modern world, is thinking about very high advanced sports activities, and we're thinking about Paralympics and how you can push their limits. Yes, it is expensive. Cost is a huge factor in rehabilitation, but I'm here to show you that technology can push you to such great limits. So I want to end my talk just spending a few minutes about one of the common areas that we discuss when we talk about technology is about stem cells. Everybody now wants to find an easy solution where you can try and do a improvement, thinking that stem cells is going to be the future in spinal cord injury or Parkinson's or brain injury or stroke. And there's a huge hope, or whether it is a hype. So we don't know what it is. So let me tell you some information. So if you look at a lot of media related information that is coming from Korea, from China, and a lot of eastern part of the world, it is like 3 weeks later, she was apparently able to walk using a walker. A complete paraplegic 39-year-old woman comes back. So imagine, tomorrow it comes in the Hindu or the Times of India or one of our Indian newspapers that, oh, this injection gives you, makes a patient walk. There'll be a huge rush of patients coming to you saying that, I'm ready to spend even 10 lakhs. If any one of us were to be paralyzed for whatever reason, and if somebody said that you spend 5 or 10 lakhs and you will have these injections and then you're going to walk, I would definitely want to spend that money. So that is what the media says. So there are enough reports, like, for example, the Chinese, Beijing has hundreds of Westerners come to Beijing for therapy. And you know what? The two countries in the world which attract stem cell treatment, one is China and the second is India. You won't believe that there are so many doctors in India who would provide you with a stem cell injection. At the moment, there is definitely no evidence that stem cell injection in the spinal cord has any benefits. The Indian government has banned, it's illegal. It is illegal to give stem cell injection to any patient unless it is under a randomized controlled trial or some trial setting. It needs the approval of the government. But there are still lots of doctors because it's very difficult to control. Even websites are banned from advertising in India about stem cell treatment. Even the legends like, you know who he is, Christopher Reeves, never had a stem cell treatment and he died and he was the longest living tetraplegic. So is it a hope or a hype? Well, it is a hype at the moment because if you say that somebody is going to get better and hundreds of patients are walking, then people don't participate in rehabilitation programs. They think that, okay, let me go have this injection, then I'll walk. I don't need to do any rehab. And they keep looking for a cure. They keep searching around for a cure. They think that this is the latest advancement, that the latest treatment for, a brain injury or a stroke or a spinal cord injury is to go and have a stem cell injection, and they lose all their money, their resources, and eventually they neither go for rehabilitation nor they have a cure, so nothing works. So if you look at what's happening in the world right now, we feel that there is an area which we can tap into. Last 15 to 20 years, there's been huge funds raised in the US, in the West, and even now currently in India, there are 2-3 centers which are doing a lot of trial on stem cells. So all these societies, the Christopher Reeves Foundation has given a huge amount of money. Several billions of dollars has been spent on research on stem cells. But at the moment, nothing is available. It is all still in the research phase. The Indian Medical Council, the Indian Council for Medical Research, ICMR, is also got very strict guidelines for how you have to do research, and every injection that is given should be enrolled in a research. So the facts are, the list of experimental therapies that have been developed in animal models has worked. So they have done a lot of animal models in rats, and it is working in rats, but we are not able to replicate that into humans. So because of the type of cells, because you are able to recreate neurons, but the neurons have to bind with other neurons. So these are called as the skeletal cells. So the neurons binding with other neurons and forming an a collage, a network of this is not happening. So we are still there. It will be groundbreaking, and I'm sure there is hope, there is a potential in the future, and there is a good promise that mankind will be saved from this devastating spinal cord injury if we have stem cells. So the hype is there. A cure for spinal cord injuries has been found, is the hype in the media, but the hope is what we have to hope for, that someday it will come. So if any of you here, I think there's about 129 of you, so your take home message is, advances in technology is very important. The advances have to be started in the early phase. We have to collaborate. I mean, I think like for example, what we are planning to do between Hamsa and the Global Rainbow Foundation, more foundations and more groups, like-minded groups in the rehabilitation space throughout the developing world should join together, join forces, and we need to develop these technologies locally. Currently, these technologies are mostly abroad and they are very expensive. And obviously, if you take a robotic, yes, Chennai has one robotic, but it is very expensive for a common man to afford. So there's another robotic system in Delhi. So the number of these are very limited in worldwide, in Asia as well. So we need to try and find devices. So you therapists should be the pioneers. You should be the ones who are motivate, your local IITs and IIMs and various of the technology platform people to develop these technologies, and only then it will benefit our Indian and Indian subcontinent population. So with this, I'd like to end. Thank you very much for listening patiently. I wanted to finish this in half an hour because we can spend some time on some discussion. I myself have not been exposed to a lot of this technology in my career. I am looking forward to hoping that this technology will come to India sometime and it will benefit us and we will learn a lot more from this. Thank you so much. And over to you, Dr. Karthikeyan.
Dr. Bala, am I audible?
Yes, you are audible.
Yes. Really, it was an excellent presentation, which has covered all the essential aspects which a beginner or a tertiary care specialist should know about rehabilitation. Just a minute, I'll open my video. So it was an excellent presentation.
Thank you.
And I would like to convey a special thanks that most of the rehabilitation specialists are still having a tough time when people or patients come and say that can we try with stem cells. The individual doctors, associations and government bodies, despite issuing a lot of notifications regarding the efficacy of stem cells, many hospitals they keep doing it without any concrete promising scientific evidence. You made it very clear that it is an hype, but it is any hype, we should not leave it as such, and it should be the groundstone for future hope. So as of now, it is an hype, and we have a long way to go pertaining to the management of spinal cord injury with stem cells. Thank you so much.
Thank you.
Fine, right. So I would like to invite Dr. Armugam Parasuraman to share a few words about the presentation and Dr. Balamurali's contribution in rehabilitation.
Thank you very much. Thank you very much, Dr. Karthikeyan and Dr. Balamurali. I must say I'm a layman in medicine, but your presentation was so clear, so insightful, and it confirms my own belief and conviction that through technology in modern times, we can really change the lives of people, especially people with severe disabilities. And you demonstrated that very clearly through the new technology available, but also through the research that has been done. And that's very, very useful and interesting, I must say. And we from Mauritius, from the Global Rainbow Foundation, but from the medical community here, we certainly look forward to benefiting from the wide experience that you have and from all the facilities that you've demonstrated that are available. So I have already got a few, in addition to our professionals attending the webinar, I have got at least 5 or 6 persons with spinal problem, spinal injury, and paraplegic and so on. They are following the webinar, and I'm sure they will benefit a lot from that. And we are looking forward to benefiting from this great experience that you demonstrated. And let me also say that Dr. Balamurali, the day before, yesterday, you examined one patient whom I referred to you, and you've changed the life of that person. By the telemedicine that you've done, the consultation, you've given new hope, new faith in that person, and now he is very confident and is facing that situation with a lot of serenity and hope. So I could see the impact that you can have on the patients, and you do it from the heart. I could see in you the way you handle those medical consultations, the mission you're conducting now in India through Hamsa, after your international exposure and experience, is really something which I feel is a great sense of giving back to society, and it's also a great sense of service to humanity. So I would like to place on record my full appreciation for this initiative, and more so the collaboration with Global Rainbow Foundation. We stand to benefit a lot from that, but also will together take your expertise, take your services, that of Hamsa, and across Africa, across places where we need to share that. So with these few words, let me thank you once again. And I've learned quite a few things from you today, and I'm sure we will look together how we can put that at the service of those people who are in need. Thank you very much.
Thank you, sir.
Thank you, sir. Of course, it is always a great thing when Hamsa Spine and Brain Rehab and Global Rainbow Foundation join together to offer their clinical services and for collaborative academics and research. So we want to put that into a concrete structure as a form of memorandum of understanding between Hamsa and GRF, Global Rainbow Foundation. I think the Hamsa Spine Brain Rehab, Chennai, India, and the Global Rainbow Foundation, Mauritius. Sir, do you have the draft of MOU with you? Dr. Bala, do you have?
Yes, I have. Just 1 minute.
Yes.
Okay, so I'm just going to sign this.
Yes, now yes. Now the memorandum of understanding between Hamsa Spine and Brain Rehab, Chennai, India, and the Global Rainbow Foundation, Mauritius, is happening now on this auspicious day, 20th August 2020, in the areas of, to have the collaborative works in the areas of clinical services academics, and research. We hope that this memorandum of understanding will benefit the clinicians, students, and all the professionals in healthcare, both in India and Mauritius. Now over to Dr. Balamurali.
Hi.
Yes.
Thank you, Dr. Karthikeyan. So I'm very pleased to say that Hamsa Rehab from Chennai is very pleased to have a memorandum of understanding with the Global Rainbow Foundation at Mauritius, where the objectives really of our intention is to refer patients for rehabilitation and other surgical interventions, to share medical faculties for training and research, to conduct rehabilitation education programs, conferences, seminars, workshops, webinars, to facilitate therapists with short-term and long-term fellowships, internships, and training, and to conduct a rehabilitation course, which is going to be a university certified 6-month neuro rehabilitation course, which we are going to start in the next academic year very shortly. And we will be writing to all of you to enroll, where we will have a lot of collaboration between India, Asia, and Europe and US, to various parts of the world, where we will have lots of faculty who will be teaching people. So this is the main objective of our MOU. It is purely for education and research and training of people in the therapy field of rehabilitation. Thank you, sir, and I'm just signing this form. I just like to say that I have signed this and I will send you a copy. Thank you so much.
Can I share a slide, Dr. Balamurali? Can you stop sharing?
Yes.
Oh, you have a few more things. Yes, please carry on.
Okay. No. What I just wanted to actually show in this slide.
Yes. Please carry on.
Yes. So we are starting from. I think it's going to be starting from a week after, which is the first week of September. So this will be twice a month, a series of lectures, which is going to cover the entire spectrum of rehabilitation. So this is our initial program. So I'll just list out these programs about recent advances in stroke, mental health in COVID, post-ICU and COVID rehab, blood bowel management in neuro rehab, role of a physiatrist in rehab, cognitive training in traumatic brain injury, telemedicine in rehab, oncology rehab, pain management, hand function and management, gait training in spinal cord injury, and speech and language disorders in neuro rehab. So this is going to be the next 6 months program, which will be twice a month. It is going to be a paid conference. The payment will be very, very minimal. It will definitely be affordable to all of you. And the reason why we've made it payment is so that you value this course, the effort and time we are going to put. None of these speakers are going to be charging money. We can never run a course if we charge money, because they're all going to be a lot of national and international speakers. But we want our rehabilitation community, both at Hamsa and GRF, and whoever wants to join us, to benefit. So we're going to have a series of these, and soon we'll also be announcing, as I said, a series of a formal university UGC recognized course. It probably is going to be a diploma course in neuro rehabilitation, which we will announce very shortly. Thank you so much.
Thank you. Just I'll share one slide. So we are. Okay. Just a minute. So we are very happy to have this memorandum between Hamsa Spine and Brain Rehab and Global Rainbow Foundation in the areas of clinical services, academics and knowledge sharing and research. Yes, just to share the joy and cheerfulness among all our participants. In this context, I would like to invite Dr. Arumugam Parasuraman after this formality of MOU signing. Just few words in this moment of cheerfulness.
Thank you very much, Dr. Karthikeyan. Let me show you my signature on the MOU. Can you see it?
Yes, sir. Yes. Yes. Yes.
So then we will be exchanging the MOUs, but this for Global Rainbow Foundation and for me personally today is a blessed day. And as you know, we are in the days when we are celebrating Ganesh Chaturthi. And Ganesha, Lord Ganesha has always been a great blessing, a great protector, and a great remover of all obstacles that I may have faced in my journey in life, especially in the service to humanity. So it's a good coincidence that we're signing it today, Thursday being another special day. And in the context of Ganesh Chaturthi, I am confident, as it has happened in my life, in my mission, that Lord Ganesha will bless us, and this memorandum will be a great blessing to many people who are in need, but also in particular to Global Rainbow Foundation for the mission that we are conducting in Mauritius and we intend to conduct in the region globally. But more importantly, this MOU from Hamsa Rehab to Dr. Bala Murali, for whom I have very great respect, and also my good friend, Dr. Karthikeyan, a person who is very visionary, who can see what we need in future, and is very committed and dedicated. So together with Dr. Karthikeyan, with Dr. Bala Murali, and with Arumugam Parasuraman, Arumugam. So, you know, all these three names have some similar, symbol or representation. So I'm confident that this day today, 20th of August 2020, will be a landmark in the service that we all committed to provide to persons with disabilities in Mauritius, in what we do in India, and also in other parts of the world. That's a great historic moment today. And I'm confident with the MOU that we've signed, with the provision for the collaboration, it will certainly make a big difference and touch so many lives and bring joy and happiness to those who now, because of not having this service, are not enjoying all these benefits. So with these words, let me once again thank you, Dr. Bala Murali. Thank you, Dr. Karthikeyan. Thanks to the Hamsa Rehab team and to all the participants for joining. I will join Dr. Bala Murali to invite you, because we are planning to have the webinar jointly organized. As Dr. Bala Murali has said, we'll have it on a regular basis, and we invite all of you, those participants who are here today, all of you, to join, to benefit from that experience, to learn, and also to share, so that this could greatly help the community that we are serving. I have a message from a young man whom I wanted to join. He's Abdul Karim Anas, who is a paraplegic and a young boy, very dynamic, whom I've asked to join. He just sent his message. He's very grateful and very informative session. And Dr. Bala Murali, he's the one that you're doing a video consultation soon, and pending more consultation that he will come over to your center in Chennai to have. So I just want to say that already you could see the benefit of this webinar as eye-openers to various people concerned. So thank you very much once again, Dr. Karthikeyan, for being the person who connects, and Dr. Bala Murali for doing things.
Yes, sir.
Thank you.
Thank you. And I also like to take this opportunity to thank Dr. Karthikeyan, who's made this connection between the two of us. And if not for him, that, we wouldn't be signing this MOU today. So, for the viewers, those who probably Dr. Karthikeyan has never introduced himself. So he's a physiatrist and he's a very well-known physiatrist in Chennai. He works in multiple hospitals, and he's also going to join, Hamsa in a more bigger role from 1st of September. And together we want to make rehab an important area of medicine, because I think, I'm a neurosurgeon, I'm a spine surgeon, and I stand far away from rehabilitation. I'm the one who causes the damage. And you are the people who rehabilitate the destruction and damage that we surgeons cause. But I feel that, rehabilitation is one area that has been severely neglected, like a few other specialties in medicine, only for the simple reason that, it is not an money-making area as a private venture for many people. And that is why rehabilitation has always taken a step back. And also, it is not only in the private, but also government policies. The government also has given less importance to chronic ailments, chronic disease, to disabilities, and it is not well thought of and studied in the developing world. The developed world, of course, they are much better. Even they have their own problems. But I guess, together we can all raise the awareness, and unless, we are the people. So we have to raise the awareness of both the private sector and the government to make sure that rehab therapists, people associated in rehabilitation, get the due recognition. And unless we fight for it and unless we make it happen, it's not going to happen. So let us celebrate this moment, and I'm sure this MOU and this association would make things better in both parts of the world, in both countries. And thank you, Dr. Karthikeyan, for your initiative.
Thanks so much, Dr. Bala, for your good words, for your magnanimous words, which is being conveyed for the respect towards rehabilitation. Because rehabilitation is a concept where many times it is being underrated by the many surgical specialties. Good that you're a rare entity who is respecting the concepts of rehabilitation. Thank you so much. I think it's a time for us to move on to the next session. Shall we move, Dr. Bala?
Yes, I think we'll move. But if there are any specific one or two questions, you can identify, then we can move to the next section of the panel. Yeah.
Okay, fine. We have one question from Mrs. Varshini Fokira from Mauritius. She is a physiotherapist with GRF, my good friend. How far would you encourage the use of electroencephalography biofeedback compared to functional electrical stimulation in the rehabilitation of traumatic brain injury or any neurological diseases suffering patients?
Yeah. So my experience is that is fairly limited. But what I would suggest is, the biofeedback is one of those areas which is fast moving, where electroencephalographic biofeedback is coming up in a big way in terms of patients with a traumatic brain injury. But it all depends again on the severity of the brain injury. If this brain injury is a severely brain injured person, then probably I'm not sure if biofeedback would be very useful. Whereas in patients with mild to moderate injury and disability, functional electrical stimulation is going to be good. Again, I said, I have no experience in this, and I'm not a physiatrist, or nor have I explored these options. So this is all that I can say. Thank you.
Good. There is one question from Smriti. Are there any tools used to measure, evaluate the quality of life of the patient prior to the surgical procedures as a part of surgical planning?
Yeah, definitely. That's a good question. Let me give you a few examples. One is an example of a spinal cord injury and a brain injury. So if you look at spinal cord injury, the predictors of good surgical outcome are, number one is the neurology at presentation. So whether it's in Asia A, Asia B, so what is the neurology at the time of presentation, the duration and how quickly the surgery is performed, the duration between presentation and surgery. And the next thing is, so whether there is an involvement of the bladder and bowel, again, it would show you whether it's an incomplete or a complete injury. And then is the associated other injuries. So these are some of the factors, including radiological factors, including the general condition of the patient, age of the patient. Younger patients do better than older patients, patients with significant comorbidity. So there are scores, there are things available as to whether this patient would benefit from this surgery, whether we do an anterior surgery or a posterior surgery or a reconstructive surgery. So yes, there are some guidelines. It's not 100%, but there are plenty of randomized trials which have shown who does better. Similarly, for traumatic brain injury, if somebody comes in within the golden hour, young patient, GCS at presentation, associated injuries, blood loss, duration between surgery and the patient is taken to theater for craniotomy. So these are all the things that will predict the outcome of the patient. So there are still plenty of studies and trials. In fact, we are now collaborating, and I'm being part of a global research grant coming from Cambridge, where we are going to study a lot of things about, in the developing world, about these factors which I mentioned, the duration of surgery and outcome. And also, we fortunately, because I was involved, we included rehab as an important factor. So we are going to see whether patients who undergo a rehab program who do better after a major injury, or patients who don't undergo surgery too. So it's going to be a study that will come out in a couple of years' time, involving the entire world. For the first time, the entire world is going to collaborate in this study. So we will have more answers. Thank you. I think we'll move on to the next session.
Yes, fine then. We'll move on then. Now it's time for us to move to the next part of this session, panel discussion on speech and language disorders in brain injury. As you all know, brain injury, whether it is post-traumatic or due to vascular insult, leads to a wide spectrum of problems affecting the cognition, cranial nerves, a motor part, that is the power, tone, balance, and bladder, bowel. The spectrum of disorders is very wide. Among this, a person who is not able to communicate or has a difficulty in communication obviously will have a very much problematic in his activities of daily living. These problems pertaining to communication, speech and language pathology requires a timely intervention with a structured rehabilitation program involving the speech and language pathologies. Here we have two experts in speech and language pathology, Ms. Shweta and Ms. Smriti. Here, during this panel discussion, they will share their clinical experience pertaining to the disorders related to speech, language, and communication. And the participants can come out with their questions. And I hope that this would be a very good discussion where we can share a lot of knowledge and ideas. Now I welcome Ms. Shweta, who is a speech and language pathologist from Hamsa Rehab, Chennai, and Ms. Smriti Venkat, who is a speech pathologist from Chennai. Smriti, Shweta, are you there?
Yes, sir.
Yes, sir.
Thank you. Yes, sir.
Very good, right. So we have our panelists now, Shweta and Smriti. So this is we use this time for us to discuss about the speech and language disorders after brain injury. Right. Shweta, can you make overview of what are all the problems as related to speech and language disorders after brain injury, and a few clinical experiences? What the impact of your intervention will really make a change in the life of a patient, please.
Yes, sir. Yes, sir. Thank you, sir. So we have prepared a few slides to discuss about what you had exactly asked for. So good evening, everybody. And me and Smriti, we welcome you to the panel discussion on speech and language disorders after brain injury. Can you please move on to the next slide, Smriti, please? Yes. So we would like to start by explaining the process of communication. So the first process in communication is reception. That is the receiving information. And the next process will be the documentation. So the documentation involves continuous ongoing recording of the information that we receive through hearing or through the written modality. The next process in the communication is formation of a network where there is transfer of information from one area to the other. So for example, when there's a conversation, we receive information through our auditory mode, and it is usually documented in our Wernicke's area, and then it is transferred to the Broca's area for understanding of the information. And the fourth step in the process of conversation is searching for the information database that is already stored in the brain based on our previous experiences. So if you have to understand a conversation, you will have to map the data that we have already learned before based on the information we have gained, the experience that we have gained. And the fifth process in the process of communication is a clouding of data. That is, you use your memory and storage to register the data and make a connection with already available information. And the last part, the important part, will be verbal communication through your speech and language. So next slide, Ms. Prati, please. So what happens after brain injury? So there are few major speech and language disorders that predominantly occur after a brain injury. So the first one includes dysarthria. Dysarthria is a speech disorder that is characterized by incoordination between the subsystems that are responsible for speech. So the main subsystems involved in speech includes the respiratory system, the phonatory system, and the articulatory system. So any weakness in the muscles involved in these systems and the incoordination between these systems can cause a speech disorder called as dysarthria. And the next one is apraxia of speech. Apraxia of speech is also a speech disorder that is caused that is executed by improper efficiency in execution of movements. That is, the systems that are involved for speech is adequate, the functioning is proper, but the motor commands, the execution of the motor commands that is required for speech is affected because of the brain injury. The next one is acquired neurogenic stuttering. So as we all know, stuttering is a speech disorder that causes influency in our speaking. So persons after a brain injury, they might experience incoherence in their speaking, causing by word repetitions or phrase repetitions. The next one is a neurogenic voice disorders. Neurogenic voice disorders will cause individuals to reduce their loudness. They'll not be able to phonate properly because of this voice disorders. It can be either because of the vocal muscle weakness or the nerve innervation weakness near the vocal cords. Next one is an aphasia. Aphasia is a language disorder which is characterized by difficulty in understanding and usage of language for communication. So this includes Broca's aphasia and Wernicke's aphasia, the two main types of aphasia. So the Broca's aphasia includes individuals having difficulty to express what they're meaning to communicate. So individuals with Broca's aphasia usually will have intact comprehension, but their expression is affected. On the controversial side, individuals with Wernicke's aphasia, so they will express properly, but the problem will be in the communication. And since the problem will be in comprehension, so since the comprehension is a problem, they'll not be able to understand what we're asking from them, and they might give incoherent answers. The next one is dementia. Dementia is an acquired neurological disorder which causes gradual progression in intellectual function, gradual decrease in intellectual functions and communication. And the next one is right hemisphere damage. So right hemisphere damage causes a set of right hemisphere syndromes that are basically caused because of the damage to the right hemisphere of the brain. So the main symptoms include emotional deficits, neglect issues, and recognition issues, along with few speech and language issues. Traumatic brain injury, any speech and language disorders that is caused because post a traumatic brain injury caused by a road traffic accident can be classified as disorders because of TBI. So again, these individuals, based on the site of the lesion of the brain, can have speech and language disorders characterized by ranging from completely no speech to gestural speech. And again, few individuals can exhibit aphasia with few other combination of speech and language disorders. The next disorder is dysexecutive disorders. So individuals with dysexecutive disorders will have difficulty in higher cognitive functions including problem solving, attention, concentration, inhibition, and planning. So these are the various kinds of disorders that are associated with brain injury. So we will see a few case examples that we had experienced at Hamsa Spine and Brain Rehab. Over to Smriti, please.
Thank you, Shweta. Thank you for the brief introduction. And we'll move on to a few case examples. So here we have a few case examples of few patients who are individuals with aphasia. And these are their pre and post treatment recordings. So I'm not really sure how many of you would be able to understand these because most of them are in Tamil, and we have included a few English wherever we can, but it's mostly Tamil, so bear with me. But I'm sure you will be able to differentiate the effects of the treatment from these recordings. Just a minute, I'm just sharing my audio. Shweta, can you hear the audio?
No, Smriti, it's not audible.
Just a minute. Yes. So this is a patient. I had given him a picture description task, and he was asked to talk about the picture. So this is what he had to say.
மீன் இருக்குது மீன் எல்லாம் ஒந்தியா இருக்கிறாங்க எல்லாம் ஒந்தியா இருக்கிறாங்க
எப்படி வந்தீங்க இன்னைக்கு? So I'm asking him what is happening in the picture. The questions that I asked him is that who is there in the picture, what is happening in the picture, how many people are there. So he didn't, all he had to say for that is that, yeah, it's there. Yeah, there are people. So that his responses are only limited to that. After intensive speech and language therapy, so this patient, he had deficits both in comprehension and expression. So we had to target his comprehension. At the same time, we had to work on his functional skills so that, you know, he can communicate well at home. He can talk to people around him. He had actually a very wide social network. I'd spoken about social network analysis in the previous webinar. So he had a very wide social network. He was a person who used to deliver speeches. He used to talk to a lot of people on a daily basis, and he's constantly instructing people. So communication was very vital to him. So after speech and language therapy, this is his speech sample.
கார்ல ஆட்டோல வந்தேன்.
ஓகே ஓகே. உங்க கார் எங்க?
கார் வந்து விற்க சொல்லிட்டேன்.
விற்க சொல்லிட்டீங்களா? ஏன்?
விற்க சொல்லிட்டு மறுபடியும் கார் வாங்க போறேன்.
புது கார் வாங்க போறீங்களா? என்ன கார் வாங்க போறீங்க? MDM கார் வாங்க போறேன். So this is one bit of the conversation that he was having with me, and he showed some significant improvement with therapy. So he was able to communicate. He was able to communicate to his wife that he actually wants to sell the car, and they made the decision together. So if not for therapy, if not for speech and language intervention, I don't think he would have been able to do that, because he was not able to use the right words to communicate, or he was not able to even express his basic needs. So his initial diagnosis was he was a transcortical sensory aphasia, but now he's moved more into the expression spectrum. So he's not doesn't have any residual deficits, mainly in comprehension. So the next patient, this is another patient, again an individual with aphasia. Audience, if you have any questions in between, you can always post them. We'll be answering them, even with the case example. So here is another patient. So initially I'd asked him to talk about cricket. So if there are any people in the audience who are not speech language pathologists, these are examples in which you can identify that there is something wrong with the patient, there's something wrong with their communication, and you can always or should refer them to a speech language pathologist who would be able to help them. Yeah, you can start.
How many there would cricket is was it about 11 days? 11 days they were the cricketing side.
So he says 7 days. What he actually means is that 11 players in each side. So he wants to say 11, but he says 7.
About the batting side, full time or you can pair or magnically or press or the pressing side or the 11 pairs about the.
So can you see the amount of effort that is required? He just wants to say there is a batting side and a bowling side, trying to explain cricket, but there is so much hesitance, there is so much blocks, there are so many, there's so much time that is taken to get out each word. He wants to say bowling, but batting is coming out again. So these are all typical features of aphasia, and his diagnosis was Broca's aphasia. So these are all typical characteristics of what falls under a non-fluent aphasia. So he was unable to continue his profession as a teacher because of his language dysfunction that, as you can see, is evident. He was not able to continue his teaching. So as speech language pathologists, it is our responsibility to try and provide as much as support to these individuals. As a speech language pathologist, you also have the authority to provide a disability certificate or provide compensations for the work of the person and try and get him to work at a better job or a situation where his communication abilities does not limit his ability to work in that profession. So it's also the responsibility of speech language pathologists to note that and try and get a job for that patient, and also simultaneously improve his or her communication abilities. So this is his speech sample after a few sessions of therapy. He's describing a picture.
She's doing that pain. This is the proportional man.
Okay. So he's looking at a picture and he says there's still a lot of thinking, there's still a lot of hesitation, but he was able to speak in continuous sentences. So he's looking at the picture, he's saying children are playing, this is a corporation man, and then he goes to talk about what kind of cars are standing there, but at least he's able to use full sentences. Initially, it was very difficult for him to even get out the words, but later at least he's able to use complete sentences with proper grammatical structure. So the next video is after a few days again. So he's trying to talk about himself here.
I am
Where are you from?
I am from Orissa. I'm from Orissa.
How old are you?
I am 43 years old. I am married. I am two children. I am 2 degrees and my.
So at least he's able to, talk about himself and engage in conversations with his wife. He has, his fluency is much better. So, with a known member of the family. So it's also important for us to put them in multiple situations, in different situations. So for this particular patient, he was more comfortable in talking in Oriya, which was his mother tongue, as compared to English. So it is also important to assess the strengths of the patient and try and get them to communicate in what they are comfortable with. So this is another patient. This is the other end of the spectrum. This was a patient with Wernicke's aphasia, and this was his initial recording.
Painted. How
are you today?
How I got painted. I find it. I want to paint.
So for individuals who are not from the SLP background, Wernicke's aphasia is a type of aphasia in which comprehension is severely affected. So these individuals can speak abundantly, but what they speak doesn't make sense. So they will create new words. They will use random words to express something that's not related to the situation. So here I'm asking him, how are you? And his response to that was that I was painting, I painted. And so he continues something that's unrelated to the question that I asked him. So initially he presented with a lot of incessant speech. So that's what is a typical characteristics of Wernicke's. You will ask them something, they'll start talking about something which will be completely unrelated. So he was like that. He did not stop talking, and it was very difficult for us to get his attention also. But with few weeks of speech and language therapy, here you can see he's taken the cards voluntarily on his own, and he's trying to tell me what he can see in those cards.
Yeah.
तय करने का.
हाँ.
तय कर लिया.
Very good. ये
है ना. ये छोटा. इसमें क्या करते हैं? सुनते हैं.
सुनते हैं इससे.
क्या सुने आता है?
हाँ. But उसका नाम क्या है?
उसका नाम है.
So he reached a level where he was able to answer questions. He was able to tell me what the picture was, what was the use of that particular item, what is the purpose of doing that. And so he was able to communicatively indicate his pain, his needs. So Wernicke's aphasia in general, it takes a lot of time, especially with his age and other comorbidities. There was not much functional improvement that was expected, but he improved greatly. He was able to, indicate his needs. He was able to talk with his wife, and his attention deficits and incessant speech reduced to a great extent. This is another very interesting case. So she is an 86-year-old lady, and when she came to Hamsa, she was paralyzed on one side and she was mute. There was no speech output. She was not using gestures. She was just nodding her head, and that too inconsistently. So when I saw her the first day, I did not expect. She was also on an RT with swallowing difficulties. So I did not expect that she would improve to such great extent. So this is a pre and post therapy video. Initially, I started off with something like a visual action therapy, considering her as a global aphasic. And we started off with some comprehension training.
Chari, Bama Bati, ball edunga kaila, ball edunga. Ball edunga. Ball enga irukku. Very good. Engitta kuduthurunga. Thank you.
So this was after about 5 sessions that she started following single step commands. Before that, she used to come to the session, she used to sit, and there used to be no reaction. But she slowly started improving, slowly started showing improvements. So we used picture to object, object to picture, all the guidelines of VAT, and to see what she has improved. This was a few weeks ago. Currently her speech and language skills are much better than what this is, but this is her post-therapy video.
திருச்சியில பிறந்தேள் எங்க வளர்ந்தேள் மாமா
So she now can speak in complete sentences. She does not have any residual language deficit. She does have a few cognitive deficits which are age related, and her swallowing is completely back to normal. She still has dysarthria, which is due to the muscular weakness that exists in her oromotor structures. Also because she doesn't have dentures. A few of you might have had some difficulty understanding what she said, but this was a great example of what speech and language therapy can do. Even at the age of 86, she improved a lot, and there was no limit, and she surprised us every day on the number of words that she started using and new sentences. She started talking proverbs, and she went up to the level where she took one of our ward boys who was working there, and she was teaching him English. So she was a teacher, that was her profession, and she decided to do that. Since she can speak, she decided to do that on her own. Shweta, would you like to talk about this patient?
Yeah, thank you, Shweta. So this patient came with a right MCA infarct. So he is a left-handed individual with an infarct in the right side of the brain. So he initially demonstrated deficits in both understanding and expression. So he was expressing few words, but there were perseverations and excessive paraphasias. So you can see the video of his initial stage now.
Yeah, wait. Give me your hand. Okay. We are going to tap. Okay, like we did yesterday. Okay. We are going to tap and say 1 to 10. Okay. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So this was at initial stage. So he was able to repeat able to repeat with few cues from the clinician. But again, when there were no visual cues, there were a lot of paraphasias. And the next video is his recent video after few sessions of speech and language therapy.
Laughing. Yeah, come on, let's try. Sing. Right. Come on, let's try. Laughing. Can you look here? Laughing. So look here. Okay, can we try laugh? Yes, that's laugh. Can we try saying it? Laugh. Look here. Look here. Laugh. Listen. Laugh. Can you try? Laugh. Good job. Good job. Okay. You know this. How is this boy going? Oh, what is he doing? How is he going? Fast. Good job. And how is this boy? Slow. Yeah, good job.
So this patient initially was very proficient in writing. So we had to introduce constraint-based therapy for him. And then we started showing pictures so that he'll be able to identify the stimuli and repeat it. So as you saw initially, he was having few perseverations and paraphasias, but with visual cues, he was able to really reciprocate. Again, he required a lot of stimulation for the visual cues. And his spontaneous, right now his spontaneous naming has improved by looking at the pictures. And if he is having any difficulty, he writes and shows us, and then we will give him visual cues for him to repeat after that. Yeah. Next slide.
Okay, so this, I'd spoken about this patient during the last webinar, and I just wanted to show, we spoke about ICF-based assessment, and I just wanted to show a model document on how you can document for any patient based on the ICF format. So I hope you can see my sharing. So this is a case study of the individual case example one that I spoke about last time. So his diagnosis was multiple cavernomas with dysarthria, dysphagia, and with a tracheostomy. So initially, you can document the history of the patient in detail, right from what happened to what when he was brought to your particular center. Then I would suggest you go on with the assessment in the three main domains of ICF, which is body structure and function, activity and participation, and environmental and personal factors. So you document the assessment in the different domains of body structure and function. Here I've not put the specific ICF codes. Ideally, you're supposed to use the specific ICF codes for body structure and function, activity, participation, and environmental and personal factors. So you use the ICF checklist initially, and then document each problem of the patient in detail. I've just given you a consensus of what I have made from after giving the checklist to the patient and the caregiver, analyzing it. And this is a descriptive way of just putting it so that we can formulate our goals more efficiently. So I've put the categories as swallowing, speech, tracheostomy, and feeding tube. These were his four main domains and what each findings were under those. So, and the activity and participation, I prefer to try and ask the patient what they face, give them questionnaires, give them the opportunity to try and tell what their activity and participation limitations are, instead of us as the clinician trying to assess what their limitations are. So, and the environmental and personal factors, obviously based on your clinical judgment. So here's what I've given. And then this next section is clinical reasoning. So based on your assessment, you have to clinically reason which goals are important, which parameters need to be targeted during therapy. And you neatly delineate those goals in the order that's responsible and the order that it's necessary to be done in. The goal setting should all obviously involve the patient, and also identify the facilitatory and inhibitory factors. These are also very important, because if any of these factors are in hampering our rehabilitation, we always have to refer the patient to another professional to try and target these behaviors. So if psychological factors are involved. So this patient recently had lost his wife. So there were a lot of psychological factors involved because of that. There was no primary caregiver with him. He was with a nurse. So all those factors come into the picture. So it's always better to refer the patient to a psychologist and try and not let those factors hamper with your intervention. Then you have the clinical goal setting by the clinician and by the patient. So it's important for you to try and discuss with the patient on what his or her goals are. Try and formulate your goals. So as you can see, as I've displayed it on the screen, these were the goals that I had picked, and these were the goals that the patient had selected. The only thing that was common was I was planning to improve his loudness, and he also said that he needed to speak louder. So most of my initial goals, without the ICF checklist, without interviewing him, without talking to him, was basically impairment oriented. Right? So when you do a deep ICF classification, like I've shown you about, that was a descriptive way of putting it, you will get a much better idea of what the patient wants. So quality of life questionnaires, or what handicap the patient is facing, is very important. You have to try and integrate that into your goal setting so that the patient feels involved in the therapy.
Thank you, Smriti. Am I audible?
Yes, sir, you are.
Yes. Thank you so much for, thank you so much, Sweta and Smriti, for a wonderful presentation. It was a good introduction regarding the speech and language disorders. And all the clinical scenarios, the clinical videos, what you have posted, has given, just now I'm switching on my video, has given a clear picture of how the impact or intervention of the speech and language pathologists can really influence one's quality of life in traumatic brain injury patients. That's really nice. We have a few questions. Quickly go through. How to improve language and communication skills for patient of post-tracheostomy?
So if there is a patient with a tracheostomy, the first thing that you need to provide them with is try and give them an access to communication, to speech. So first assess their language skills. If they can communicate verbally, try and give them a speech valve so they at least can communicate functionally, whatever their speaking ability is. Even if there's very minimal loudness, give them a speech valve. Try if they can tolerate that and start communicating verbally. If not, if their language abilities do not permit that, try and indicate an ASE as soon as possible. So along with your language intervention, you have to give them an ASE so that they do not feel handicapped by their communication.
That's nice. And we have one question from Lesin Hanan. What were the therapeutic strategies used for the Broca's aphasic patient? What are therapeutic strategies in Broca's aphasia?
So for that Broca's aphasia patient, the first thing that I had to do is to try and get him to use his stronger language. So he was using Oriya very confidently. He had no language deficits such as word finding difficulties or sentence structure problems. So it was a typical bilingual aphasic case. And so the strategy that I used with him is Oriya to English. So it was orthography to speech. So use the Oriya orthography, try and get him to convert that into English and try and communicate, because his goal was to try and speak better in English. He was not able to communicate with his wife in Oriya, and that was the main reason. Other strategies which were impairment based were VNIST, and communication based therapy was mainly PACE. So these were the three strategies mainly used.
That's good. We have one question from Rajalakshmi. How to plan therapeutic approaches to this executive disorder as an speech language pathologist? And at first, in which area we have to focus more on these cases for speech therapy? Then what are all the speech characteristics we observed in these cases? A dysexecutive disorder.
So in a dysexecutive disorder, there can be a plethora of symptoms. It's not limited to one. They have all deficits, like Shweta had mentioned, in higher cognitive functions. So it's definitely necessary to try and control the functions that affect our intervention first, instead of directly targeting on communication. So you try and target those skills such as attention, orientation, other cognitive functions that impair speech in the first place. They might not have any true language deficit or true speech deficit, but the other higher mental functions and executive functions might be hampering their speech and language status. So you try and control them first. If you're not able to do it on your own, please try and involve a cognitive psychologist with you so that you can get to it faster. And then see if so once the executive functions are out of your picture, you will get the true picture of your speech and language. Only then you can assess speech and language in detail. And after you do, speech and language therapy will be simple. So wherever you can try and integrate those approaches. I think Shweta would agree. What do you think?
Yes, Smriti.
Thank you so much. I think we have had a very good session on speech and language disorders with the introductory session and the questioning and questions and answering. It's very nice. I think we have covered all the questions now. Now it's the time for me to thank everybody who have contributed for this session. My sincere thanks to the GRF team and Professor Armugam Parasuraman. Sincere thanks to Hamsa team who has put their efforts and time in making this webinar session a grand success. Special thanks to Sweta and Smriti. Thanks to Dr. Bala for his excellent presentation. And thanks to all participants for spending their time here, take part in this academic session. We are looking forward, all of you, for the forthcoming webinar sessions, which will be covering in all aspects of rehabilitation, the sessions from experts in all the domains of rehabilitation. I thank you one and all. I wish to see you all again in the forthcoming webinars organized by Hamsa Spine and Brain Rehab. Thank you all.